All right. First, I want to say good morning and thank everybody for joining us today for our first of two best practice call series. Today, we're going to hear from two speakers in our network service area on how their facility culture has driven success. I do want to do a couple meeting reminders on behalf of the IPRO ESRD network. So we do host these calls, and we utilize data and interactions in the community to find these best practice speakers to bring them forward for you all. We would like you guys to listen in, write down any notes, ask questions. These are high performing best practice facilities in our network, and we really would like you guys to take away if not everything that they share, at least one thing today that you can implement at your facility. So today we're going to be talking about culture. I do want to encourage all of you all to attend next week's session. It's our second session, and that's more on patient engagement in the community and how that can improve outcomes. So May 14th, today's the first one. Make sure you sign up for the one on the 21st next week as well. My name is Caroline Sanner. I am opening the call today, but you're going to be hearing from Yvonne Heavner and then two of our facility staff members about what they're doing at their facility that's driving success. So without further ado, I'm going to introduce Yvonne, or she's going to come on the call and introduce herself and get our first speaker started.
Good morning. I wanted to introduce Patty Bryant. She is a social worker. She's out of our Network One service area, and she has a great presentation on how leadership can impact facility culture, morale, and even patient outcomes. She's got a wealth of knowledge, being a dialysis social worker for a number of years, and such passion for it that I can't wait for you guys to hear her presentation. So I'll give it to you, Patty.
Thank you, Yvonne. Thank you, Caroline. It really is a pleasure to be here, and I'm so pleased to be able to talk about something that has become really near and dear to my heart as I age. I've been a social worker for about 30 years and have worked the majority of my career in healthcare, having cut my teeth in an inner city hospital. I understand there might be some Ohio people here, so shout out to Mount Carmel Medical Center in Columbus, Ohio, that has since closed, but that's where I cut my teeth as a baby social worker, working in a number of different medical areas: surgical intensive care, cardiac step down, oncology, a number of places, until I finally found dialysis. And this was back in the day when dialysis units were still owned by hospitals. It's been a very long time ago. But we had a unit in the basement of the hospital, little windows kind of at the top, and it was very dark. And what was interesting, though, is that the medical director of that unit really had a progressive view about modalities. And so we had folks coming in 6 months ahead of time before they started dialysis for modality training, so their access placement could be coordinated before they even start dialysis. So this is back in the early 2000s. And so our population was half and half at the time, but I learned so much about dialysis, and I guess that experience caught the bug. And I have spent the majority of my career then in dialysis units, working with 5 different dialysis companies. And I was counting the number of directors of nursing, clinic managers, nurse managers, whatever you want to call them, at least 11 that I've worked with intensely. And then, of course, a multitude of others. And of course, the multidisciplinary teams in those units that have been wonderful. So as I've aged, I've really gotten some ideas about what works in a dialysis unit, what doesn't, some of the things that we'd like to see in terms of developing culture and leadership. So that's what I'd like to share with you today. I want to start with really the role of the social worker. So those of you who have worked with us know we're a quirky sort, but very loving, of course. Next slide, Caroline. Just a few things about us, and this may ring true to you. We certainly have a strong sense of right and wrong. And if you ask my husband, he says I'm bossy by nature. And so I think many of us are pretty bossy, tongue in cheek. We understand really what good leadership looks like and the consequences in a dialysis culture when the leadership is developing, shall we say, or not so good. We really don't want to be the primary boss person. We prefer a backdoor approach. We really prefer leading from behind, being the one that whispers in the ear person who's having leadership on their shoulders. And so we're really good at supporting leadership. And that's one of the roles in the dialysis unit. In addition to taking care of all of our patients, we're there also to help take care of staff and to strengthen leadership. We really don't prefer the spotlight, but we're getting good at getting others to talk. So yeah, you'll see good facilitation there. I like to say, and I have my dietitian buddy here in my unit bought me a pair of rose-colored glasses. We really like to focus on the positive. We understand what motivates behaviors, and we choose to focus on that. And in that, we're able to kind of see a process that goes beyond what we're seeing manifested in front of us in terms of behaviors. So again, getting at that motivation. Next slide, Caroline. We really want to focus on where a patient is going. So we search for ways to make interactions therapeutic. And as you're watching us round in the unit, you may see us talking about our favorite little chit chat topics. I have 26 chickens, so that's sort of the comedy that I roll with in the unit sometimes, telling about chicken drama. But out of that, it's not just chit chat. We are looking for cues about, maybe what the person likes to do, what they connect with, what they don't connect with. And all of these things we're storing in the backs of our heads so that we can use these things down the road in a therapeutic environment and helping them process perhaps how they're dealing with dialysis and find tools for coping based on their likes and dislikes. We really are advocates in the dialysis unit for the patients. We want to make very clear that we are not the enforcers. So while we are people who have a lot of ideas about how to manage behaviors, we do not want to be the primary mouthpiece of that. So we may be the one whispering in the ear of the technician or of the nurse dealing directly with a behavior. We're going to teach them how to nip it in the bud and deal with things in the moment so that we can come around behind and then support that. Because if we're seen in the dialysis unit as an enforcer, then that completely cuts us off at the knees in being able to work with a patient toward progress. Also, we need to work lean now. Let's be honest. Dialysis is a business. It's no longer that hole in the wall in the hospital that's a not-for-profit. It doesn't really matter how much money we're making. We are completely results driven in this day and age, and so we have to work more leanly. We have less time. We have more patients. We have more documentation, more goals to meet, more screens to complete, et cetera, et cetera, et cetera. So we are master's prepared social workers. And so our work product really needs to be commensurate with that. So we try not to get bogged down in some of the tasks that are involved in logistical management of the dialysis patient. I'm going to pick on transportation because I know everybody, it's the bane of our existence. If you're a social worker or a person working in the unit, it takes an enormous amount of time. But what I want to say is that we try to encourage the patient to be independent. It's not my job to do it for you. It's my job to teach you how, because we are not sitting in the chair. Ultimately, the patient is the person who needs to function well. And that is our whole role in the dialysis unit, to help them function well. So if we're teaching them some agency in their situation, maybe they'll feel some of that power and be able to take some things on that maybe they didn't realize they could. So as I'm thinking about leadership, we see that there are a lot of consequences to poor leadership. Next slide. Let's look a little bit if leadership is less strong than we would want it to be. Lost revenue. We're missing out on things being documented properly, missing out on goals that we may have set as a dialysis unit, goals that CMS sets for us. We have poor staff and patient satisfaction. Poor staff retention means we have high turnover, we have training costs, and all of these things that will really drag a unit down and slow us in terms of our progress. Positive changes out of poor communication take longer to implement. So if you're communicating that you want something to happen and then you don't reinforce that change over time and it kind of goes back to where it stood before, then really you've wasted time and money. There's increased stress in a unit because nobody really knows who's got this. Who is going to hold the unit accountable for these things, or the staff accountable? When there's mistrust in that way, then it takes a lot longer to get things done. Not only does the staff and the patients feel unsafe, but you spend more time fielding complaints. And as a social worker, we're one of the primary folks who hears about it, and it takes a long time to talk someone down when they're really upset about something. So conversely, let's focus on what happens when we have strong leadership. We've got this sense of calm. Everybody knows what's expected of them. They know the rules. They trust that who is setting the rules is going to reinforce those rules. The rules are explained to everyone so that they make sense. Patients feel well cared for. The staff feels safe and well cared for and appreciated. And when a staff feels appreciated and well cared for, and that somebody's got their back, they will stay. And guess what? When they stay, we have a wealth of experience and years that we can draw on, and the units run so much more smoothly. So how do you get to that? And I've been thinking about that for quite some time, and I was looking for a framework about how to think about leadership in the dialysis unit. And so if we go to the next slide, I want to talk about an author that was recommended to me by my brother. My older brother, 9 years older, he was a vice president of agricultural lending at Chase for a while. So he's had a high corporate job. Now he owns a motorcycle dealership in Central Ohio. So he's been a boss of a small company. So he has some idea of the challenges involved with being in different layers of leadership. And he recommended this book called The Speed of Trust by Stephen M.R. Covey. And this may be a familiar name to some of you. His father actually wrote The 7 Habits of Highly Effective People, and that would be a familiar title. Stephen Covey, apparently in this family, they're really a brain trust of organizational behavior, because several generations here have focused on that. And Stephen M.R. Covey owns a big corporation and was able to come in and see it take a turn from one that was developing to one that's incredibly successful. And he wrote a book called The Speed of Trust, the one thing that changes everything. That really resonated with me as a healthcare worker, because how many times do we hear people say, oh, I don't trust that person to put in my needles, or I don't trust this, or I don't trust that. If there's no trust, there's no calm, there's no peace, and there's no progress. So let's dig into this. He envisioned the idea of trust having 4 cores. And he looks at it sort of like a bank account. Your trust is your bank account, and you have behaviors which will put deposits into the bank account, and then you have behaviors that will put withdrawals from the bank account. So let's focus on how we build up this bank account of trust so that our units run well. The first core is integrity. And so this essentially is honesty. This is walking your walk, talking your talk, being congruent inside and out. The second core is intent. These are your motivations, your agendas, your motives. Trust grows out of a sense of shared intent and knowledge that the intent is good in a situation. Mistakes are always made, but sometimes if you make it with the best of intentions, people are much more likely to forgive and partner with you in making improvements. The third core he talks about is capabilities. So that is essentially the talents that we have, our attitudes, our skills, our knowledge, and our style. And these are the things that we bring to the table in our different disciplines to produce results. Results being the fourth core. So results, oh my goodness, in this day and age, whoo, it is all about results. You know, we have our QAPI, we have our ICE dashboard, we have our Medicare guidelines, we have all of these things that we are now having remuneration attached to, and we have to meet these goals. So obviously we have a good idea that we want to bring to our unit our care, our concern, our talents, but now everything that we do is directly related to the fiduciary success of the business. So, no pressure there, right? Next slide, please. Now, this is where we get into some of the fun stuff, because I'm really summarizing his book and really chunking it down for you. But for me, the most important thing that I got out of the book were the 13 behaviors that we can all do as leaders in the dialysis unit. And I'm saying leaders, but in particular, the clinic managers, the directors of nursing, those are the folks in our units that really have the weight of the world on their shoulders, because they are the ones that are aware of all of the financial issues, the meeting of goals. They're aware of how difficult it is sometimes to make payroll, all of that. And they're trying to translate all of that business knowledge and stress into caring, concern, all of these things that they have to show out into the dialysis unit with the patients and the other staff members. So I hope that some of these behaviors and going over them is going to be helpful, particularly to those people. And then to those of us who are social workers and other support staff, to be aware of this so that we can support you in all of that. The first behavior is talk straight. I can't tell you how many seminars I have attended where the talk that comes out of the mouth of the presenter is it's almost like you're in a study, and it's so formal and so far from reality. Sometimes it's really hard to listen and hear what the person is saying. I'll give you a few examples. I was in a seminar earlier in the year, and I heard comments like facilitating meaningful engagement. What do you mean? Talking? Creating a different truth around transparency. Various voices in the context of presenting. Can we bring compassion to those moments? So I don't know, maybe the last one isn't so bad, but the others, there's probably a more direct way to say things that will get through to people. We have to remember that our dialysis clinics are filled both with staff and with patients with all different socioeconomic status, psychosocial issues, educational backgrounds, linguistic backgrounds. We want to be relatable. So I'll leave that there. The second behavior is demonstrate respect. So we, again, along with that, we come from all walks of life. We want to make sure that the person that we're speaking with feels respected. Stephen Covey talks about the waiter rule. Maybe some of you may have tried this in your dating lives, but I used to. It was kind of interesting because I was a wait staff getting through college, so I remember being on the flip side of this. But you're sitting across from and you're sitting at dinner, and you really watch how that person interacts with the wait staff. So it says a lot. It says a lot. We are all human beings. We don't elevate ourselves above other people. We want to make sure that we speak in such a way as to make that very clear that the person that we're speaking with feels respected. Number 3 is to create transparency. So you want to tell the truth in a way that people can verify. You don't want to have hidden agendas or to hide information. Dialysis is a small world. We know that something is going on, whether or not it's being said outright. So as best you can as a leader, please share with the staff, why certain things are happening. Please share with the patients why certain things are happening. And recently in our region, there's a clamp issue. Some of you might be familiar with, patients are now needing to hold at least one of their sites and then maybe clamping one of their sites. And so in order to make that kind of a change flow well, if you've been accustomed to having 2 clamps on after your treatment, you need to make sure that you share the information so that it makes sense to people why this is happening, why we need to do this. Number 4 is to right wrongs. All right, so we all make mistakes. Unfortunately, it's part of life. But if you approach a misstep, shall we say, with humility and grace and ask for forgiveness, then it's much easier to ask the people that you're working with to work toward restitution, to have them partner with you. So very, very important. Which leads, and then to number 5, which is show loyalty. Don't talk about people behind their backs in a negative way. Because it is a small world, the word gets around. It really does. And so you don't want to ever compromise a person's ability to do their job. So, I mean, I'm thinking kind of more about staff interactions and less about patient interactions in this one. But if there is some correction that the leader needs to make with a staff member, please think about where that's happening. Too many times, patients will witness interactions out on the aisle. It's just completely inappropriate. Because again, if someone is being chastised on the aisle, or if another staff member is in altercation verbally with another staff member on the aisle, that's going to compromise both of those staff members' abilities to work with the clients that all witness that in the future. So just be aware of where you are. Be charitable. I mean, assume that we all want to do well. We all want to perform our jobs well. We all want to be successful in dialysis. You know, even the folks with the most challenging behaviors are coming to treatment. So obviously they want to be there. Try to assume, again, those rose-colored glasses, the best about somebody, and be charitable as you talk about them. All right, so number 6, we're moving on. Deliver results. So this is where, you know, clinic managers sometimes know what the goals are, but please don't feel that you're all alone in trying to deliver results to the higher ups. Involve staff in those goals. You know, make sure staff understands that we're trying to hit whatever number with whatever metric, and we're gonna attend to this right now, because you know what, we can take it. Staff members can take it. We can take it, and you know, we like to be a part of success. Also important to make sure that the commitments that you make are realistic. You know, as you're delivering results, making sure that things are realistic. If they're not, then you kind of take it back to the table and then realign what your goals might be and come back at it. Which leads to number 7, which is get better. So this is showing progress. Instead of looking at an issue like it's a mistake, for instance, you might count it as feedback. You know, CMS requires 2 times a year these long surveys, satisfaction surveys, that the patients who are kind enough to fill them out fill out. So that's feedback for us in order to get better. So if we think about mistakes, not as mistakes, but as a process and as feedback, maybe that gives us a little bit of grace, perhaps, to think differently about our goals and achieving our goals. Number 8 is to confront reality. Be realistic. You know, difficult conversations have to happen. Difficult behaviors have to be addressed. That's where social workers can come in, even if we don't think that we are necessarily the right mouthpiece to deliver information. We are more than happy to help whoever might be the right mouthpiece, if it's the clinic manager or the head nurse, delivering information to a patient about something. We're more than happy to try that conversation out, to make sure that we have everything on board that we need to have that conversation, whisper in the ear, and then follow along behind. So making sure that you have the support that you need to be a good leader is so important. Everybody ought to have somebody who has their back. Everybody ought to have somebody who has their back. Number 9, clarify expectations. So you're having meetings with your staff, like reset meetings with your staff about maybe different goals and rules that are coming down. You're meeting with patients and making sure they understand. You're communicating ahead of time what the expectations are in a very clear way, so that then you can measure them down the road. Practice accountability is number 10. And that's first holding yourself accountable as a leader, making sure that anything that happens in your dialysis unit, comes from what you communicate. So you are accountable to patients and staff in that. And also giving people credit for the things that they do, because there are a lot of really talented staff members that have made incredible contributions to the team that really, I'm sure, appreciate being recognized. Number 11, and I'm going to take a minute with this, listen first. As Stephen says in the book, generally, as long as a person is communicating with high emotion, he or she does not yet feel understood. Think about that. You got the patient, all of us have had this happen, right? The patient's yelling. And people are saying, calm down. Well, they're not going to. They're not going to calm down until they feel that someone is taking a moment to understand why they're so upset. So a person will usually not ask for our advice until he or she feels understood. To offer advice too early will usually only stir up more emotion or cause someone to simply ignore what you say. So this is where, again, social workers go to How to Talk to People school. So please use us in situations where it's really a difficult behavioral issue. We'll try to help tease out the best approach for this. And in the moment, if we're there, I'm sure that we will have your back and be a part of that conversation. Number 12, keep your commitments. If you commit to something, do it. If you say that we are going to all change our chair times to a certain time for second shift, then do that. Don't let it kind of go back to the way it was before, because that is a withdrawal of trust if you don't follow through on some of the things that you said that you were going to do. And certainly don't spin it. Don't try to spin it if for some reason it doesn't work out the way you think. Create a head-on approach to that and make sure that you address that from a very realistic, commitment-driven position. And then the last one, not the least, extend trust. So, like I said before, we can handle it as staff members. We are very talented, smart, dedicated, caring people in this profession. Otherwise, we wouldn't live in it for so long, because it's hard. What we do is very, very hard. So understand that the leader in the dialysis unit who knows every single staff member also knows where their talents are, knows the talents and maybe some of the things that need to be worked on too. But you've got a lot on your plate as clinic leaders. So why not delegate some of those tasks that could be delegated to the people who have talents in those areas, and ask them to step up to the plate and have some contribution to the success of the unit. Many examples of that, but I know that we're getting a little bit short on time. So I'll end with that. I don't know if there are any questions, but I really appreciate the opportunity to talk about leadership and about culture. And I wish you all the best of luck as you take this out into your own units.
Does anyone have any questions for Patty? You can put them in the chat, or you can raise your hand. Oh, it looks like Vicki has a question.
Okay.
No, I just wanted to thank Patty. I think that this is so great to hear how you support leadership and are part of a really great leadership team. I think your ideals and your practices are right on target, and hopefully it'll create some resiliency in the facilities to, it's been a hard road after the pandemic, right? So I think we all need to pull together behind these concepts and get the joy back into working together. So thank you very much.
Oh, Vicki. Thank you. That's perfect. You just summed it right up there. That's the whole motivation behind all of this, because we do have a lot of joy. There's no reason why we can't have joy, even with the pressures that we have. And we go in and out of burnout all the time in this business. And hopefully a little jolt of additional information and energy can help us all. So thank you.
Thank you, Patty. Great presentation.
You're welcome. Thanks to everybody.
I see some other hands up there.
Oh, are there other ones?
Yeah, you'd have to go into the view all.
Oh,
They actually just dropped.
Oh, yeah, that's interesting. Okay.
Oh, wait.
I couldn't get into the chat. This is Sue. I couldn't get into the chat, but I just wanted to say what a wonderful presentation on leadership. And the way you did it through the book, I love it. So I thought you did a wonderful job. And I can tell what a great social worker you must be. So thank you very much for the presentation.
Thank you, Sue. Thank you.
I agree.
Go get the book.
I agree. And I was raising my hand and putting it down because I was trying to get into the chat too, but that was excellent. You are clearly have a passion for it and wonderful experience and smarts, and a lot of most of everything you said just resonated, you know, for me as a social worker in dialysis, and also a veteran social worker for many, many years. So thank you for that.
Yeah.
Very nice.
Got to keep up the fight here, guys.
Wonderful. Thank you all so much for, well, thank you, Patty, for your presentation. That was amazing.
Thank you.
I'm interested in reading this book now, honestly, but
Yeah.
I thank you for our audience for being so engaging, having questions, and kind of giving us that feedback of Patty's presentation. So if you guys have any more questions while the next presentation's going on, feel free to keep utilizing the chat. If you had issues with the chat, you might be able to use it now, but if not, just raise your hand and we'll call on you at the end of the next speaker's slides. So I do want to do a shift, keeping with the theme of today of facility culture, you know, really driving to improve outcomes. Our next speaker is going to talk about their culture and how it relates to transplant success. And so I'm going to do a little intro. This speaker is a social worker. Her name is Michelle Vasquez. She works at Wellesley Dialysis, Innovative Renal up in Massachusetts. Just to give you guys the background for this facility, they are a facility with a census of 72, and they have 36% of their census already on the wait list. Now, 36% already on the wait list is a huge number. It's an incredible undertaking. It shows the past work that they've done is currently in play, and it's reflective of their outcomes. I have some data from the last 12 months projected on the screen. So 36% already on the wait list. In the last year, they added 3 more onto the wait list. 3 of those waitlisted patients were transplanted. And I know we're talking about transplant here, but home starts, so those direct from CKD or direct from the community to on home, there's 8 patients. And then also their census moving to home, they had 3 patients. And so just an overall powerhouse. There's a lot of other really great demographics data-wise that they have been able to exceed. I know their vaccination rates are through the roof too, but to really highlight this high percentage, the facility is continuing to get roughly 6.5% of their population waitlisted, which is over the national average, which is only 5.3%. So slim pickings with the patients remaining to get on the wait list, and they're still able to get them on there. So Michelle Vasquez is going to speak on just how they do it. Essentially, I was pretty blown away when I heard about their culture approach. And so I would like to invite Michelle to unmute and share about her facility.
Thank you so much for that intro. My name is Michelle Vasquez. I am a social worker, so I have been working in the field for about 3 years now. My previous work was with children, youth, and families, so quite a shift while I started working at the dialysis clinics. I've learned a lot, and so I just wanted to give a little details on what we're doing in our clinic. By no means am I an expert. I think that this, you know, sometimes there's things that we can do to help patients get transplanted, and then there's sometimes things that we can't do. So I think it's important to understand and you know, get to the understanding that there are people that can't be transplanted, unfortunately, and we have to know that, you know, there's nothing that we can do. But the people that do have that option and, you know, have that hope, I think it's important for us to encourage that and do everything we can to make sure that they reach that goal. So just to start, so what we do in our clinic, so the way we approach things is we really have organic conversations with patients from the beginning. From admissions, we talk about transplants, so we always discuss that being an option, even if a patient may not seem like they're a good candidate. Of course, the doctor would always determine and the team would determine whether a patient is a good candidate or not, but we always bring it up as an option for a patient to try. You know, we do a referral if that's something that they want us to do, and we take it from there. To really strong conversations. We have a really great team. So one of the things also that we have in our clinic is that the main team has been there for a very long time. So I've been there for 3 years, but a lot of our nurses have been there for 15 years. You know, one of our nurses have been there 15 years. Our PD nurse has been there for 8 years. Dietitian has been there for 20 years. So a lot of our main core staff has been there a very long time. And we really work as a team to push for these things to happen. So if there's any barriers as a team, we have these conversations, and I think that's really important. So one of the most important things that we always talk about is like building a really strong relationship. So even outside of conversations about, you know, just assessments and day-to-day things that we have to do, we also, for me, it's important to build a relationship with the patient. So not just focusing on, you know, what their numbers are, what their labs are, what our goals are. Also just talking about, you know, what did you do this weekend? How's your family? You know, what are you doing outside of dialysis? I think it's really important to do that because it builds a trust between you and the patient. And it shows them that you're not just interested in meeting these goals and making sure that they get to their treatment. You're also interested in how they're doing. And it also just gives you a way to also support them in other areas they might need support in. They may not be willing to engage with, let's say, a therapist if they're having some depression symptoms, or they may not be willing to, you know, go to a specific doctor that they need to go to. And when you have a different type of relationship, I think that really helps. So building that rapport from day one of the things that we do in our clinic, and we really try as hard as, you know, to make sure it happens. I'm usually present for our admissions. There may be, you know, 1 or 2 times where I'm not available because I do cover 2 clinics, but in general, we try to do admissions when I'm present. So I sit with the patient from day one. I go through the admission packet, and we sort of have, you know, this time to bond and build this relationship from day one. And I think I found that that's really important because they do see me as that go-to person to talk about any concerns, and they do remember my face. So that's a big thing. I know that's not possible for everyone. But even if maybe not the social worker, if there's one person in the clinic that could be the go-to for admissions, I think it's helpful because you also get into that routine of knowing how to have these conversations. So it's just easier. So even if it's not the social worker, if there's a nurse or the clinic manager or someone that's able to be the go-to, that's something that we also find helpful. Okay, so the next slide. So the other thing that we find helpful is, so we work with a lot of different transplant centers. So there's Boston, you know, we're centered around Boston. We work with tons of centers. And we do work primarily with certain centers, but we will send a referral wherever the patient feels most comfortable. Sometimes if a doctor is affiliated to one, you know, center, or they've been working with this center, we will send the referral there. But sometimes patients, let's say they are denied at one place, we might try a different hospital. So just, you know, keeping that communication open with all the centers is really important. So one of the things I've been doing, we tend to call. So we've been calling the transplant centers every few months just to check in. So we do get a lot of fax. They send over letters sometimes through the mail, or they fax it over just giving us an update on patients. But sometimes that gets lost. Sometimes we found that a center feels like they've sent us some information and we haven't received it. So making a phone call is really important because we get that information. We can share that information with the patient. Sometimes the patients have been informed through mail that they, you know, are either active or they have to work on certain things, and they either didn't get the letter, didn't open it, or it got lost somewhere. So it's really important for us, and something that we really think is helpful, is calling the centers every few months just to, you know, just to ensure that there's no updates. If the patient has had to do any type of workup, that, you know, we're receiving that information. If I have to be the person to sort of encourage the patient or support the patient, making sure that they're doing those things, we find that very helpful. So again, as I stated in the beginning, a strong core team, strong culture is very, very important. So I think it's helpful what Patty's presentation was about. So having a strong team, low turnover, high trust is important. We can't always help the turnover that happens in the field. I think it's just the work, and it's not something we can necessarily control. But when there is a strong core team, it's very helpful. If there are people that have been there long term, feel like even with turnover, there's always a few people that have been around. It's helpful to have those people be a part of the team, because it shows the patient that the company, the clinic, is committed to to helping them. And so it's important to have someone that is the go-to person. So when you're focusing on transplant, if you have somebody, a different person every time, calling the transplant centers, talking with the patients, it doesn't feel as organic to them, I feel. So I think it's important to identify one or two people that can really be the go-to for this. So I think hope and trust is really important with success and pushing for referrals. We always encourage patients. So again, of course, depending on the person's age or comorbidity, they may not necessarily be a good candidate. But I'm never the person to give them that notice. So I always encourage someone, within reason, if it's a patient that's, much older, and we know from the beginning that they're not a candidate, but we always just try. We have them have a conversation with the doctor. If the doctor feels like there could be a possibility, we encourage that referral. And we also encourage second opinions. So we have had several patients that may be denied in one hospital for comorbidities or for certain medical conditions, and then they go to a different hospital that may consider them. They may need some workup, they might need to complete certain surgical procedures or something, and then they're transplanted. So we've seen that happen. So it's really important to keep the hope. If the patient wants to do a second opinion, I always encourage that. We have someone right now that's going through a second opinion at 2 separate hospitals. So it's just important. I know it's not always going to turn out in a positive way. There are people that just are not able to get the transplant. But if we feel like, if the doctor feels like there's hope, if the patient really wants to continue trying, then I'm, of course, going to always support the patient until the very end, until, they're just not given a no by everyone. But I will always try to support them in reaching their goals. And this is just a case study. So again, it's just really being supportive to the patient. So we had a case study. This was one of our PD patients that was on the transplant list for several years. The patient was active and was coming close to the time where he was going to be transplanted. And so he was really struggling with his weight and his PTH numbers. So we've noticed that a lot of the hospitals in the Boston area are very specific about the PTH number being at the level that they want. And so that patient's level was going up and down, and there were concerns with whether the patient was taking the medications. And then the weight was also, he was a patient that always was a little bit of a lower weight, but we wanted him to gain some weight. So that was something that the team really rallied behind him, making sure that, he was taking his medications, making it clear to him that, this was going to be a barrier if he didn't ensure to take his medications. The doctor also got on the phone with the transplant team and had a really in-depth discussion about the patient's weight being, it was always, his weight was always around this time. So we did help in having conversations. The dietitian met with him, helping him, gain some weight. The nurse, me, like we all really had strong conversations with him every month, and he finally was transplanted. So it was wonderful to see him get through with that, because it was a big goal for him, young person, and was on the list for a long time, and we were just able to get him to do that. And so it's just the team is really important. Being active on the list is not always enough. Sometimes you have to push for the patient to make sure they're still being, adherent to coming to treatment, taking their medications. All of that's important. We find that even after someone's active, if they're called again for a reassessment and something is not going well, they could be inactive again. So you just want to make sure that even if someone's active on the list, that you still continue to check in, still continue to ensure the patient is, doing what they're supposed to, taking their medications, staying the target weight. All of that's really important. And so again, it's just making sure that the team is involved in having these conversations with the patient. So that's all on my end. Again, I just wanted to share what we do in my clinic. Does anyone have any questions that they have right now?
Hello.
Thank-
I actually have a question if I'm able to ask.
Absolutely.
Hi, my name's Samantha Carlo. I am the manager of a very small dialysis unit up in northern Maine. Um, I have how do you get your patients to be interested in it? I have one patient who he is the ideal transplant patient. He's never had a blood transfusion. He's got a very common blood type. His kidneys died because he had an enlarged prostate, which his urine backed up, killed his nephrons, not because anything's actually wrong with his kidneys. He still works full time. He's in his early 50s. And we have brought up to him transplant several times, and he is just not interested. And it is baffling to me that you could be able to get off of this machine and continue to live your life. He's got 4 grandkids. He travels to see them. Like, he's got a good life. And I don't understand how to encourage him that transplant is a good thing. How do you get people interested?
Yeah. So this is definitely, this is just my take on this. I'm sure there's a million different answers. So I think it's important to think about or engage a conversation about his long-term goals and involving, not necessarily involving his family in the conversation if he's not comfortable, but just trying to envision what is the future, what does he envision for his future? What would that look like if he wasn't on dialysis? What would how would things be easier for him? Because dialysis, we all know that this is a very difficult treatment to be a part of. It interferes with your daily life, with activities you do during a vacation. If you're working, it's just, right in the middle of your day. It takes up a long time. And so I think it's just important to have those conversations and not necessarily push for it, but have open conversations about what is life for him before he was on dialysis. What are things like right now? And then what does he envision for his future? And try to focus on those goals and how would things be different for you if you received a transplant, and maybe also talk about, maybe he has some fears around transplant. Maybe, maybe he's afraid about the outcomes, because the outcomes are not always guaranteed. I have had conversations with people that are completely against transplant. And some of the conversations have been about, I'm stable right now. I don't want to mess things up. I was sick for a very long time. Right now I'm feeling good. Dialysis is now fitting well into my life. So some of those things, I think people get comfortable with it because they become stable and they feel like, okay, my life is going fine. Why do I want to do something that might change that? So it's just important to have conversations about future goals and what would life look like once he receives a transplant, but also having realistic conversations about times that it doesn't go well. I mean, we don't want to push a patient to do something that we feel is in their best interest, but maybe there's not always a positive outcome. I absolutely always want people to have transplant as an option, but I also feel like it's important to have realistic conversations about the times they don't go well, because, we don't want a patient to be, feel like we're pushing for something and then they don't have the outcome they wanted. So just having conversations, building a trust with him, and just focusing on his future and how things would look like if he received a transplant. Sometimes we feel something would be best for a patient, but it might not always be. And sometimes transplant is not the option for someone. I mean, I always think we always feel like transplant is the option, but for someone else, it might not be. So I think sometimes we have to sit with that and be okay with it as well. That's my take. I'm not sure if that was answering your question or not. That's just the way I feel.
No, that's perfect. Thank you so much.
Yeah, okay. Any other questions?
Just to kind of assist the last question, we did have a user or an attendee of the call share that peer mentorship and success story sharing is also a great approach when you have a patient who is not interested or maybe hesitant or could be fearful, different emotions that they're feeling. A lot of times connecting them with someone who's been through it or is trusted at the clinic from a peer level is very successful. I'm looking at some other chats, and we have another attendee suggested to just approach him about what's holding him back, because it seems like there seems to be some reasons. And there was a question about religion. so the patient ended up being Jehovah's Witness. And so the reason was they didn't believe in transplant and blood transfusions. And so there could be an underlying reason. Maybe we just haven't been able to uncover it yet. I don't think I see any other questions, but lots of kudos, and there might be a hand
Hey, Caroline,
up.
it's
It is
Patty.
Patty. Yep, go ahead, Patty.
Hey, Michelle. Great
Hi.
presentation. It's just wonderful. So we talk about this a lot, and we are seeing more and more mental health issues in the dialysis unit. And it's just been a real barrier to getting listed and staying active on the list for transplant. I know that there have been some transplant clinics that have insisted on certain requirements, like that, you know, folks are linked with counseling and stay stable on their meds and everything. But it's a unique situation, and we don't ever want to discriminate, you know, for people to get a kidney. But have you had some experiences like that, some frustrations, or any insights into how to help someone who struggles with mental illness stay active on the transplant list?
So we have. So I can think of one patient at the top of my head actually that was denied, and we really couldn't get him listed actually. So this patient had mental health and some cognitive concerns as well, and the family is involved, but not enough to support a transplant. And we weren't able to get that patient listed, and the doctor was sort of rooting for it and hoping that they would do it, and they really wouldn't, because it's just so important for them to keep a medication regimen after transplant, or they'll lose it. So that's huge. We do have several patients that have mental health concerns that are actively in treatment, have very good family support, and they're active. And I think that it's really, really important for them that we stay involved with making sure they're seeing their mental health providers. I know we can't ensure that happens, but just checking in with them, asking them if they're going to their therapy, if they allow for a release for you to just check in with the therapist to see how things are going, not necessarily having to get into depth on what the conversations are being had, but just ensuring they're going. And sometimes also involving the family if the patient allows you to talk to the family. I think that's really important. So we do have several. I think, like you said, in dialysis field, we find that a lot of the patients are here sometimes because of mental health medications they've taken in the past, and so it's really common. And so I just think it's important to keep that communication going and ensuring that if they don't have a mental health provider, that you try to help them connect with one if they're willing, and just checking in regularly, make sure that they're engaged. That's the best that we can do, I think. We wish so much for our patients, and we wish that they would do things for themselves. Sometimes that doesn't happen, but we just have to do the best we can while we see them and having those conversations to ensure they're engaged. That's what I would say, Patty.
Excellent. Thank you.
Yeah.
All right, so just going to look at the chat one more time. There's no other questions, it seems, for the speakers. So I think unless there's any other questions that come up, I think we're good to close the call out. On behalf of the IPRO ESRD network, I want to thank all of our attendees for coming and being so engaged, asking questions, sharing insights. Everybody supporting each other in this fashion is exactly what we want to bring to these types of sessions, because the problems exist no matter where you're located, and your patient population, they do transcend. And so I want to give a huge thank you to both of our speakers for bringing such unique and unique approaches, and also sharing like what they're doing at their facility that's causing them to be so successful. I saw one more hand get raised, but it might have been on accident, and I am correct. So with that, thank you all for joining. Join us next Tuesday for our second series, and then you'll be able to see these slides and this presentation on IPRO Learn in the next couple of business days.
Thank you, everyone.
Thanks, Michelle. Thanks, Patty.
Thanks, everybody. Have a great day.